How do we turn this?
I'll turn it on for you.
Oh, no, I'm a mover.
All right, the PowerPoint is posted for you guys. Can y'all see it?
The on button.
And then this is a clicker. You can forward it that way.
Cool. So I'm going to do a quick introduction real fast because I know you guys have probably seen me creeping around. My name is Julie Rapp. Like she said, I'm a military spouse, so we're only going to be here for about a year. That's why I'm here. I'm not going through the UAH program. I'm actually doing another university in Texas. And Ms. Poole is so kindly calling me an expert. I'll take it. But I'm definitely not the subject matter expert. I did work 2 years postpartum doing charge nursing. So I have seen a lot of interesting things and learned a lot. But I'm actually a board certified med-surg nurse. So postpartum kind of was my deviation from the norm. So we're going to talk a little bit about it today. And if you guys have any questions, please feel free to ask and participate so I'm not just standing up here going on and on. Okay, so like Ms. Poole said, we're going to do a review. Some of you, this may be the first time hearing it. Some of you, it may be a review, but we're going to go over some physiologic changes that occurs in the postpartum period. We're also going to do the focused postpartum assessment, and then we're going to discuss complications and care plans. So the way that the slides are laid out, you guys have probably seen them, is we're going to talk about our normal assessments, what's normal in a postpartum assessment. We're going to talk about what's not normal in a postpartum assessment, and then our care plan. And we're going to use the BUBBLE-T acronym to go through. And then we're going to discuss discharge teaching. So let's talk real quick about the different types of units. I haven't been to Huntsville Hospital or Crestwood, or Crestview. How are the units there? Is it all in one unit, or do they have separate labor and delivery, separate postpartum?
Crestwood has like some rooms that are labor, delivery, recovery, but then they have some rooms that you labor.
Okay, so it's a combination of both. So that's definitely going to change the way that we transfer patients, right? Because if we are delivering the patient and then we're recovering the patient, that's a little bit different. And if you have a labor and delivery nurse and then you're transferring to a postpartum nurse. I was strictly postpartum. I never delivered any patients. So if you put me on L&D, I'd be like, I don't know what's happening. I can deliver a baby maybe, but you know, that was not my area. I did strictly postpartum. So it's definitely going to change the dynamic. And then of course, you know, the newborn rooming in versus, you know, if there's a nursery. So, as most of you guys have seen this, the BUBBLE-T acronym, this is our focused postpartum assessment. So that is going to be how the slides are laid out. Okay. So let's start with the first B, rest. Okay, so what's the first thing we're going to do when we get a patient when it comes to breast? We're going to find out what their feeding plan is, right? So the American Academy of Pediatrics suggests that exclusive breastfeeding is the way to go, okay? Can you guys hear me okay back there? Okay. So that's what the American Academy of Pediatrics is saying. And that, when I say exclusively breastfeeding, I'm saying nothing but breast milk for the first 6 months, okay? That's not adding formula, supplementing, exclusive breast milk, okay? So, what are some reasons why a woman would not be able to breastfeed? She may be wanting to, but why would she not be able to breastfeed?
HIV.
HIV, that's a good one, yeah.
Not producing any milk.
Okay, why would they not be producing milk?
hormone problem, could be
Okay.
breast removal.
Okay, so that's called hypoplastic breasts. That would cause low milk production. If they have polycystic ovarian syndrome, that could cause low milk production. Hypothyroidism could cause low milk production. One thing I saw a lot, breast reductions, okay? Breast reductions can cause a lower milk production. Sometimes augmentation as well, because that definitely changes your breast tissue. And then what about medications? What are some medications that people would not be able to breastfeed? So a lot of them are like chemotherapy drugs, some sedatives, seizure medications. Tell me if I'm going too fast. Anything that's going to cause suppression of breathing, right? Because that does go through the breast milk, right? So if that's going through the breast milk, then the baby could possibly get that and then have reduced breathing. So, first step is to find out, of course, what the plan is. And always be supportive of what your patient wants, right? I've run into it a lot where you have a lot of nurses who are very scolding when the patient says, you know, I really don't want to breastfeed, I want to formula feed. You just have to make sure that your patient is educated, right? They know that breastfeeding is best, but I've always said a fed baby is best, right? So we want to support our patients in whatever decision they're making and make sure that they're educated about the decision they're making. So the initial assessment for the breasts should be that they are soft within the first 1 to 2 days. Why is that? Why are they soft and not filled?
Because your milk is until like day 2.
Correct. So that's when we produce our colostrum, right? That's the first 1 to 2 days. We're going to produce that thick, rich yellow, like the picture, colostrum. That's going to be the first 1 to 2 days.
So is that one of soft because of the colostrum?
Yeah, so the colostrum is not a supply and demand type thing like breast milk is, right? So with breast milk, that's a complete supply and demand. The more you feed, the more you pump, the more your body says produce more, produce more, produce more. Colostrum is a set amount. So that's why they're softer, is because you're not producing this crazy amount. Because when babies are born, I think it's like within the first 24 to 48 hours, their stomach is like the size of an almond. And then it grows to a cherry and then to an egg. So colostrum is not a supply and demand thing. After about 2 to 3 days, you can see here the picture kind of shows you. After 2 to 3 days, you're going to start producing a little bit more. Your milk's going to come in. The breasts are going to appear full. And then after about 3 to 5 days, that's when they're going to be their fullest. That's when that supply and demand is really going to kick in. So if you're feeding a lot and your baby's eating a lot, or you're pumping on top of feeding, you're going to produce a lot more. What does a normal nipple assessment look like? What should your patient's nipples look like? Intact. That's a big one. Yeah. What else? What color should they be? This is true. It does depend on the person. But what are we looking for as far as skin tone? Should it be red?
It should be consistent with their ethnicity.
Okay, that's a good answer. But should it be red?
No.
Okay, no, it should not be. Should there be blisters? No. Okay. So what if we have a patient who says, I don't want to breastfeed, I don't want to pump, I want to formula feed, I want my breasts to stop doing what they're doing. How do we help them? Yeah, so we want a supportive bra, right? Cabbage leaves. They're the soothies. They're like a cold
It's like a gel kind of.
gel, yeah. And those can help suppress lactation. And we don't want them to do any type of breast stimulation, right? We don't want them to take warm showers where the warm water is going onto their breasts, because that's going to stimulate production. Now, what if we have a patient who says, I don't want to put the baby to the breast, but I want to pump? How are we going to treat that? We're going to treat them just like they were breastfeeding, right? We don't want the milk production to suppress. We want them to produce. We're just not latching baby on. So here are some potential breast complications that we'll see. So engorgement. This is more leaning towards mastitis with the redness, but engorgement is where the breasts are overfull, right? How are we going to help them with that? Okay, yes. What are we going to see in engorgement? Warm rags. Yeah. What are we going to see in engorgement? You guys got it? So it could be a clogged duct, but engorgement is more overall breast tissue. So it's just where your body has produced a lot and your breast is very full. Not necessarily a clogged duct, but that can happen.
Like someone who who pumps and has fed their baby bottle all day but hasn't expressed it.
Exactly. So we're going to see, again, it's supply and demand. So if you are feeding your baby and then pumping on top, and you go, say, 4 hours before you do anything else, by then your breasts are probably going to be pretty full. And so what are we going to see? Redness, right? Swelling. They're going to be really hot and very firm. What about nipple assessment? What are some things, we kind of already talked about what abnormal findings are. Blisters, yep. Why would somebody have blisters? Yes, so an improper latch. So if we have a patient and we assess their breasts and we see that their nipples are red, sore, blistering, cracking, we want to educate that patient on proper latch, right? And we also want to help them. So if we have a patient who has that, hey, next time you feed your baby, I'm going to come in and we're gonna see if baby's latching so that we don't have that problem. Okay? So again, breastfeeding education and support. The treatment plan for engorgement is going to be feeding, emptying the breasts, right? We don't want to empty them all the way because again, it's supply and demand. So if we continue to empty them, they're just going to refill and we're going to go around and around and around. So we want to make sure that if they're breastfeeding, they do more frequent feedings and that if it's getting to the point where it's uncomfortable, you can put ice packs or soothies. Sometimes, not all the time, right? Because we don't want to suppress their lactation. It's a fine balance between lactation suppression and overproduction. And then nipple care. I'm sure you guys have seen it if you guys have been in the postpartum area. Lanolin is your best friend. It's your patient's best friend. Okay? Smother it all over. It's not going to hurt the baby. The baby can get it in their mouth. It's not going to hurt the baby. But you want to educate your patient on lanolin. That's definitely going to help. And just to touch on nutrition, so if you have a breastfeeding mom, you want to make sure that they're aware that they probably need to be taking in a little bit more calories to help them with milk production. So about 500 calories a day is the proper amount for a breastfeeding mom to take in.
500 additional calories?
500 additional calories. Not total calories, that would be torture. Best time to initiate breastfeeding is in the golden hour. Have you guys heard this term? Yeah, so what is the golden hour?
The first hour after delivery.
Yes, the first hour after delivery, okay? This is when the baby is going to be most alert. And that's when you want to initiate breastfeeding. What's another benefit of doing skin to skin for the baby? Temperature regulation. So temperature, I'm sorry if I keep pointing to her, she's just the one I hear. So temperature regulation, that's a really good positive benefit from doing skin to skin. What's another one?
Glucose reg.
Say what is it?
Glucose regulation.
Okay. I'm looking more on the mom side.
Okay.
Bonding, I heard somebody say it. Bonding, so that's a really good way to help mom bond with baby. And so when you have baby skin to skin, we're going to be watching the baby for signs of feeding. So what's going to be a good sign that baby's ready to breastfeed? Rooting, turning his head, possibly smacking. These are all good signs that baby is ready to latch on, okay? And this is a really good time to observe mom and see where her knowledge is. Because you can take breastfeeding classes all day long, but when it's actually time to put the baby on the breast, it's a whole different story. Okay, so that'd be a really good thing to assist mom and help her kind of put her knowledge into practice. Breastfeeding is going to aid in uterine contraction, so that's really important and it helps prevent maternal hemorrhaging. Any questions on the breasts? No questions. All right. So let's move on to the uterus. So the fundus should be firm. We don't want a boggy uterus. We want a firm one. Okay? Right postpartum, the first 24 hours, it's going to remain around the umbilicus. Okay? So when you go in there to do your postpartum assessment, be aware how far postpartum your patient is, because that should tell you where their fundus should be. About 1 centimeter a day, it goes down, right? If I'm not mistaken, they still chart it with the finger.
Chart with finger breaths below.
Yeah.
The umbilicus or above the umbilicus.
It's been a few years since I've done postpartum nursing, so I might have to hit Miss Poole up for some knowledge. So, what's something we want to tell our patient when we go in there to do a fundal assessment? Okay, right? Why are we doing it? Why are we beating on this patient? Why are we massaging their stomach? Okay, because a lot of people don't know. It's not common knowledge after people have babies that they're going to have this ball in their stomach and the nurses are going to come in and start rubbing on them and it's going to cramp and it's going to hurt. So we want to make sure that we talk to our patient and we want to tell them why we are doing it. It's a really good time to talk about, bleeding and how much is appropriate, what we're looking for, what we're doing, okay? So don't just walk into your patient's room, hey, I'm Julie. Start rubbing on their fundus, right? And they're like, oh my God, what are you doing, right? We want to make sure we communicate with our patients. So, why would we have a boggy fundus?
Bleeding.
Okay, what would cause it? So clots, so what would cause a boggy uterus is uterine atony, right? So when our uterus contracts, yes ma'am.
Just to go back, we're massaging the fundus to like stimulate the contraction so it can be firm
Yes.
instead of boggy.
We don't want a boggy uterus.
So that's why we're massaging
Yes.
it to prevent it from a boggy uterus.
Yes.
Okay.
Yeah, because if we have a boggy uterus, then bleeding becomes an issue. Because when it contracts, it's contracting the placental site, it's contracting all of those vessels in there, and so that's preventing the hemorrhage. We have uterine atony, that's what's going to let those areas dilate, and that's when you're going to have bleeding and clots. So if we're having clots, and we'll go over clots in a second, if we're having multiple clots, then that's when we need to do a fundal assessment to see, are we firm, are we boggy, where are we at, okay? What happens if we're deviated from the midline? So what happens if you go to feel for the fundus, and it's over here? Bladder distension. So automatically, we're gonna tell the patient, go pee, right? And then we're gonna reassess. And then we're gonna chart. So, Uterine care plan. Pain medication. What are pain medications that are given to pretty much anybody who's postpartum?
Toradol.
Toradol. Did they give Toradol now? Oh, okay. That's a new thing. Tylenol, Motrin. Tylenol and ibuprofen. Maybe that was a Army hospital thing. You know, we give everybody ibuprofen. Water, drink it, be good, take a nap.
They give them Motrin as well.
Yeah.
Some physicians give Toradol, some give Motrin.
Yeah.
They give them Norco too.
Oh man, they get the good stuff here. Again, we were an Army hospital, so it's like, here's some ibuprofen, you'll be good. We also want to educate our patients, and this kind of goes back to the clots. We want to make sure that they are tracking how much they should be bleeding. We want them to know clots are okay, but if we see clots of a certain size and then there's associated bleeding, we want them to notify us. So we'll talk about that when we talk about lochia, but definitely when we're doing the fundal assessment, we can talk about that. Any questions on the uterus or the fundus?
So the fundus is boggy or regular bleeding, right?
Yes. And we'll hit it when we talk about lochia. We're going to talk a lot more about boggy versus firm, and then the amount, clots, we'll go into that in a minute. The next one, the fun one with fun pictures, bowel assessment. So we're going to assess for hemorrhoids, okay? It's a good time when you assess for lochia. You're going to be looking for hemorrhoids. It's all kind of a one-shot, assessment. The abdomen should be soft. Not the fundus, the abdomen should be soft, right? Bowel sounds should be present. And also realize you want to educate your patient. They may have had a bowel movement during birth. So, if you have a patient who was regularly having bowel movements every 2 to 3 days, that their next bowel movement may not be for a few days. And you definitely want to talk with your patient about their first bowel movement, especially if they've had episiotomies. Because a lot of them will hold it, and you want to make sure that you talk to them about it and that, ease their fears about the first bowel movement. Has anybody had children in here? A few of us? Okay. So you guys know what I'm talking about, right? I was scared to death. Hemorrhoids, okay? So how do we treat hemorrhoids? Okay? So topical treatment, right? We're going to do stool softeners because that's going to ease it. Generally, hemorrhoids will resolve on their own. What if you have a patient who's complaining of all the classic symptoms of hemorrhoids, but you inspect and you don't see anything? They could be internal. So you always want to document what the patient says, right? The patient is complaining of burning upon bowel movement, and then that way, if they do have an internal, you can start that care plan. Constipation. What could cause constipation? Yeah, that's a good one. So meds, right? A lot of the C-section patients are on narcotics, morphine. That could cause constipation. If you have a patient who was preeclamptic and they're on magnesium sulfate, that can definitely cause constipation. If your patient was in a long labor, could be dehydration. So those are all things that we want to be aware of. I know when I worked postpartum, they gave everybody Colace. It was like Skittles. Who wants it? You get it. Another thing that we see a lot is gas pain. So if you have a patient and you assess them and they're saying, yeah, I've just been having this really weird pain in my right shoulder. It won't go away. It's kind of a shooting pain. That's gas pain. Okay, a lot of times it'll radiate up to the shoulder, and especially in our C-section patients. So treatment. We already talked about hemorrhoid treatment. Another thing besides doing tucks, we could do sitz baths, and that can kind of help soothe those symptoms. Constipation, we talked about Colace, right? And then what Colace does is draws water into the stool. So it makes the stool softer, which makes it easier to pass. Pericolace is a combination of Colace and Senna, and that is going to not only soften the stool, but it's going to draw water into the intestines and help it move easier, okay? Another thing we can do for constipation, ambulation. Ambulation, ambulation, ambulation for all your patients. Get up and walk. It's going to help you feel better, especially our C-section patients. After we do their initial ambulations, we want to make sure that we encourage them. A lot of times the pain, they won't want to, but after they get up and start walking, they will feel so much better. Make sure that they increase fluids and make sure they increase fiber. They eat easily digestible meals. And if we have somebody with gas pains, we're going to give them simethicone, which is safe for breastfeeding. And we're going to make them ambulate. Yeah. And then another thing a lot of people don't see is don't let them use a straw to drink, right? Because that introduces more bloating, more gas. A lot of. Everybody good on bowels? No questions? You guys are an enthusiastic group. I love it. Okay, let's talk about the bladder. So our C-section patients, when they come to postpartum, what do they have? A Foley. Okay, so we're going to be documenting I's and O's, right? Making sure they're putting out enough. We want to make sure that our patients are able to void spontaneously 8 hours post-delivery. And we want to make sure they're emptying their bladder completely. What constitutes a good void? How many milliliters?
At least 30 an hour.
So we're looking for, in one sitting, we're looking for 150 milliliters, okay? That way we know that they are emptying their bladder and that they're not having any issues. And we want to make sure we document that. You like this slide? Easy, right? Bladder complications, distension. They're not able to void, so their bladders are filling up. What's that doing to our fundus?
Displacing it.
It's deviating it, right? So we want to make sure that we can catch that earlier because that can end up causing hemorrhage, okay? So we want to make sure we catch distension. What could cause distension in a patient?
Inappropriate Foley count.
Okay, so say you have a patient just delivered, they have a 4th degree laceration, right? Could that possibly affect bladder, right? We have swelling. If they had epidural anesthesia, that could affect it. If they had an instrument-assisted birth, that could also affect. So bladder care plan. Assist the patient going to the bathroom. You want to see them void the 150, okay? What if they can't go? What if your patient is, oh, I'm sat on there and I'm just really having trouble getting that much out, I can get a little bit out. What are some things that we can do as a nurse to help them before getting to the point that we have to catheterize them? Turn the water on, we can get the perineal bottle, we can fill it with lukewarm water, and we can have them squirt it on their perineum to kind of help, relax. But one thing that we need to make sure that we do is, when we're documenting I's and O's, right, make sure you know how much you're putting in the bottle, because if they go and they squirt, and then they pee just a little bit, but then the hat says they went 250, right, you want to make sure that you're doing the math there. So what if they're unsuccessful? We've done all the treatment that we can. We've given the patient, 8 hours. What then? We're going to have to straight cap. We have to get the order. But at that point, we're going to have to straight cap, and then we're going to start the process all over again, right? Any questions on bladder? Pretty straightforward stuff, right? I know it's kind of hard to see, but I really wanted you guys to get the concept of colors on this one. So, lochia, the first 3 days, you like that? Because you can explain dark red, but what is that really? So, dark red, that should be the first 1 to 3 days. Every patient is different, right? So you might have one patient who only bleeds rubra for 1 day, okay? So you want to make sure that when you're documenting, you're using this terminology. Day 3 to 10, your serosa, brownish red or pink. And then alba is going to be yellowish white. Again, times can differ for everybody. Amounts are going to vary from scant to moderate to a large amount. Alba, that's going to be a little bit harder to document if you have a patient who gets to that point in the hospital. But you just document it as alba. What odor is it supposed to have? I said that. What odor are you expecting from lochia? Earthy, fleshy. Yeah, so you're not going to smell something foul, right? It's supposed to smell fleshy, not foul. And I have had patients in that predicament. You'll definitely know it when you smell it. What are you guys talking about? Oh, come on.
They were trying to figure out what it smells like. And
Period.
It smells like your period.
Very similar, you know.
How do you smell what your period smells like? I said, you don't smell your period?
I love the little sidebar comment. But see, you're right, it does. It's not supposed to have a foul odor. It's supposed to be a fleshy odor. It's supposed to smell like blood, kind of. So complications we're going to be looking at, large amounts of lochia, right? Clots bigger than the size of a golf ball with associated bleeding, okay? And a foul odor, okay? If your patient is saturating a pad within 15 minutes, you need to assess your patient, okay? Saturating a pad within 15 minutes, you're going to start assessing for hemorrhage, okay? And always, 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 when you are assessing lochia, don't just pull their underwear down and look at their pad. If they are laying down, you want to make sure you are looking under their buttocks, because it can be slipping through their buttocks and pooling under their back, and they're not aware that it's happening. And you see on the pad, oh, they're scant, right? But it's pooling underneath them. So you always want to make sure that you kind of have the patient lift up a little bit. You check all the way back to make sure. Okay. So if we have a boggy fundus, what is the source of our hemorrhage? The source of the blood loss? Anybody? No?
What's the question?
So if you have a boggy fundus, why is it bleeding?
One of the 14s.
Okay.
Like apnea.
Put you on the spot. So uterine apnea, right? Okay. So uterine apnea, we're looking at bladder distension. That could be another reason. Okay. But overall, uterine apnea is why it's not bleeding. The uterus is not contracting like it's supposed to. It's where the uterus is not contracting like it's supposed to. Yeah. Now, what is?
How are we gonna know? Because I got lost.
How are you gonna know what?
The bog is foggy.
So if you feel for that patient's fundus, and you'll be able to feel for a firm fundus. It's like a ball in their stomach. If you don't feel that ball and you start massaging, usually it'll firm up and you'll be able to feel it. But if you can't feel it, it's a boggy fundus.
Okay, what's that source? I guess you know what I'm saying.
It's because the uterus is not contracting like it's supposed to. Okay. Bladder distension is also another reason why, because the bladder is preventing the uterus from contracting like it's supposed to.
The word you'll see in standardized testing is involution. I think you have that in your book.
And we talked about that when we talked about the uterus and how it involutes 1 centimeter a day, every 24 hours. Now, what would cause blood loss if your fundus was firm? Retained placenta. Besides retained placenta, anybody think of anything else? An internal laceration. So that's also going to be the blood. When you assess the blood, a lot of times if it's coming from the fundus, it's going to be oozing. If we have some that's coming out a little bit faster, squirting, we're looking at a laceration, whether it's a vaginal laceration, a vulvar laceration. So we want to make sure we document that as well. We could also be looking at hematomas. That's another reason. So what's the first thing we're going to do if we have a patient who's bleeding? That's right. Massage the fundus. We're going to massage, massage, massage. We're not going to leave the patient's bedside, right? We're going to educate the patient that as you're massaging, they might produce excess amounts of blood. They also might produce excessively large clots, okay, like in the picture. Because that's kind of scary if you're a patient and this nurse is pressing on your stomach and now you're passing clots the size of a softball. So we're always going to stay by the patient's side. We're going to educate them why we're doing what we're doing. We're going to tell them, hey, there might be some big clots, but I'm here with you. You know, we're gonna call the physician. And a lot of times they have hemorrhage carts. Mm-hmm. Yeah. So when I was doing this, there were not standardized hemorrhage carts. That was something that was kind of put into place, and that's really a good idea.
And when we talk about postpartum complications, I'll go into more detail about hemorrhage and postpartum hemorrhage and that complication, and go into detail about nursing interventions and what other interventions you might see as well.
This is a skimmed surface. So one thing I will tell you guys is if you have a postpartum hemorrhage, you want to keep their pads. You want to keep the pads underneath them because you will weigh them. Because you want to make sure that when you document, you're being as accurate as possible to how much they actually bled. The equivalent is, yes?
So you're going to massage even if, so they're bleeding, but you don't know if it's because of a laceration, you don't really know why, but you're going to massage like regardless.
So if they have a boggy fundus, massage regardless, right? If their fundus is firm, we want to investigate a little bit further, right? Is it, well, how's the bleeding look? So we're going to assess their loci at that point, see the type of bleeding. Like I said, is it oozing? And then again, if we see a laceration or a hematoma developing, that's something else that we can investigate. So yeah. So it takes a little bit more investigating when they're firm. If they're boggy, we know why they're boggy. Let's just massage, 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 and try to get it firm. So I was saying the pads, 1 milliliter is equivalent to 1 gram, approximately equivalent to 1 gram. Another thing that we're going to be watching for while we're doing this is signs of hypovolemic shock, right? We want to make sure that we are watching for those signs when our patients could possibly start, hemorrhaging. So if you have a patient who's complaining of weakness, they feel nauseated, they may look gray, these are all kind of red flags, right? And at this point, if we suspect a hemorrhage, we definitely want to get more people involved, right? We definitely want to hit the call light. We want to call it to the nurse's station, say, hey, I have a possible hemorrhage, and then they'll know what to do. They'll bring in the hemorrhage cart, they'll notify the physician, they'll insert another IV, start the patient on fluids. So there's kind of steps to taking care of a hemorrhage patient, and like Ms. Poole said, she's going to go into a little bit more detail on those interventions.
You can take a break.
Oh, okay. You guys want to take a break?
A 10-minute break.
I'll leave that picture here.
I'll take that for me. Okay.